pragmatic, in the trenches talks about what's involved in actually delivering virtual reality treatments in the clinical trenches. And we're going to hear from two of our lab members who have been doing that for quite some time. Josh Fouladian and Karisma Kothari, who have been pushing that cart around our hospital, the aha moment cart, as I called it this morning. And they've been on the front lines, bouncing that thing through the hallways, having people ask them, what is this thing all about? Having patients ask them, what are you rolling into my room? What is this? So I thought, why don't we just hear from them? What experiences have they had? What works, what doesn't work? How do we actually implement a virtual reality clinical service at Cedars-Sinai? So Karisma and Josh, come on up and share your wisdom with us.
And welcome, and it's really an honor to be here, and thank you, Dr. Spiegel, for that introduction. So today, I'm Karisma Kothari again, and this is Josh Fouladian.
Hello,
and
everybody.
We have been working on delivering inpatient VR to the patients at Cedars-Sinai, and pretty much here is our study team. It is led by Dr. Omer Liran, who is our principal investigator, and he is also a licensed psychiatrist, as well as an in-house software developer and programmer for all of our VR software. And then once again, Dr. Brennan Spiegel, and we have Dr. Janice O as our co-investigators. And then the rest of us up there are the study staff that normally go in to come and deliver inpatient VR. And now I'm going to hand it over to Josh, and then I'll return in a moment.
Thank you, Karisma. Thank you all for being here. It's very nice to put faces to names and emails. As you can tell, we run a very tight ship when it comes to our virtual medicine conference. But in addition to that, one of my favorite parts of my job is taking care of our patients here at Cedars through this clinical service. So just a little bit of background. This service started as a consult service for chronic pain specifically. So before we launched, there was actually no dedicated service to chronic pain. But because of the great responses we've had from our patients, we also see acute pain patients and trauma patients. So we see the breadth of all pain you can imagine at a level 1 trauma center. And with these two different types of pain we're seeing and treating, we have different pathways that we deliver virtual reality for. A research pathway that Karisma kind of alluded to, and also a pure clinical pathway. I'll talk about both of those. Right now, I'll talk a little bit about the research pathway and our data collection. So again, we have a research protocol. It was submitted and approved by the Cedars-Sinai Institutional Review Board, and we ask validated surveys, the numeric pain rating scale, state trait anxiety inventory, simulation sickness questionnaire presence, things of that nature. We also collect qualitative data through a debrief following a VR session. The headset itself also collects metadata. This is things like orientation of the head in space, how long a certain video or experience was watched for, as well as other metrics like pupil diameter, heart rate, and heart rate variability. So I'll briefly go over our inclusion and exclusion criteria here. We define chronic pain as pain that has been persistent or recurrent for at least 3 months, with this acute on chronic aspect of 3 out of 10 pain reported within the last 24 hours. Our patients should also be at least 18 years of age. I won't go through all the exclusion criteria. The main ones I'll mention are the first two. So conditions that interfere with physiological signs, anything like sepsis, arrhythmias, tachy or bradycardia. This is because this would interfere with the headset metadata collection. Also, I'll briefly mention what Dr. Irwin and Brian Minton mentioned a couple of talks ago, the active treatment of GI cancer. We exclude those patients to not withdraw from the clinical trial because we use the same program. So just giving you a little insight on how these little VR projects can overlap here at Cedars. So the flow of the service. I've talked about the different types of pain we see and treat. I've talked about the research pathway and the clinical pathway. So how does this all look? So right now we receive referrals through an email we developed through Cedars. We are working with our IT team to get this through the EMR, and that should be done tomorrow. It's been very easy to get that done with the EMR and IT team, but no, it has some delays. So we are working on that. We'll get it done eventually so providers can actually drop a referral through the EMR. We then assess for eligibility. Karisma and I will look through the chart meticulously to assure all the inclusion criteria previously were met and none of the exclusion criteria were. And if they are eligible, we put them through the research protocol. So we ask some what we call pre-VR surveys. These are immersive tendency questionnaire to assess their baseline level of immersion, as well as the numeric pain rating scale and the state trait anxiety inventory. Whether through the research protocol or clinical pathway, they then have a 15-minute VR session, and we'll talk about the program that's used in a little bit, but that's a 15-minute session. Following that session, the people in the research protocol then have post-VR surveys. This is, again, numeric pain rating scale, state trait anxiety inventory, then simulation sickness questionnaire, as well as the presence questionnaire. These also assess level of immersion in the virtual reality program after their use. And then with both pathways, there's then a debrief. So we ask patients what they thought of the program, the experience, how they thought it could help them in the future, if they want us to come back again. And with the research protocol, we do collect this qualitative data. With the clinical pathway, we do not. And it's also worth mentioning, why are we doing this here at Cedars? This is really, what this is what we've done to set ourselves up for success. So, of course, we have a virtual reality team here at Cedars, which is absolutely fantastic, and I have the honor of being part of that team. But as Karisma mentioned, Dr. Spiegel and Dr. Laurent are also clinicians, gastroenterologists and psychiatrists, respectively. So them having those connections, that training, expertise, connections in the hospital adds validity to that service when we bring it to our leadership team. I went to infrastructure, so I'll stay with infrastructure. And because of those connections and that training, we've also developed great partnerships with other services. This is when I shout out and thank Dr. Bob Chernoff, who's right here from our inpatient psychiatry team, as well as Dr. Neha Dera from inpatient hospice and palliative care. And finally, we have the honor of working with fantastic internal medicine residents here at Cedars, Drs. Mather and O, who were mentioned earlier. And because we're able to work with them, they helped us write the protocol, implement the service, and also get the word out to their other co-residents and attendings. Jumping back up to our patient population, I really think this is a huge part of our success here. I'm sure many of you have heard about affluent individuals seeking care at Cedars-Sinai, but this hospital is a 501c3 nonprofit hospital. We recognize our commitment to our community, and we care for many of the marginalized groups in our community, and it is our pleasure to do so. And because of that, really what we're doing with this service, all in one go, all in one cart, we're bridging disparities in pain treatment and outcomes, mental health treatment and outcomes, and also digital health access, all of which have been extensively described in the literature. Jumping to the third bullet point here, the research enterprise here at Cedars. So this is something I see that underscores everything I've talked about thus far when Dr. Spiegel and Laurent, we've secured multiple NIH grants, also adds validity and gravity to this service when we try to implement it extensively in the hospital. And now our VR cart. I know Dr. Spiegel had mentioned this earlier today. I'll just go through a couple of the aspects of this cart. The first is the cart itself and the VR headset. The headset you're not seeing here, it's behind the little drawer. But of course, that's a huge part of this service and the cart as well. The second and third are the clean box and cleaning supplies. So we use, after every use, the clean box for a minute. We put it in there, let it clean for a minute, and we also subject the headset to rigorous cleaning with basically industrial wipes. Those are the purple wipes covered by number 3, as well as lens wipes and anti-fog wipes for the lenses themselves. The fourth is a laptop cooling device. So we like to say here at Cedars, we push our VR to the max. That will definitely tend to overheat a computer, so we have that laptop cooling device constantly cooling the laptop. Finally is the virtualist, the namesake of this session. And with a virtualist, we're able to put all this together and make it look like this. Great, so you can see the clean box. I won't go through the whole video, but you kind of get the idea. And also, with the virtualist, we have programs like this, Nature VR. Karisma will show a video in a little bit, but this is basically 8 nature-based scenes. Dr. Irwin also talked about it earlier. 8 nature-based scenes, and within each one, there are 3 different modalities. There is the just chill option, where people can just relax, enjoy the scenery, as well as the very nice audio. There is also a guided meditation separately, and also a breathing exercise. So within each one of these 8 videos and experiences, you can go into these different modalities. And with that, I will turn it over to Karisma for patient experiences. Thank you, Karisma. Thank you.
For that wonderful, very detailed, actually, overview of our virtual reality inpatient service, as well as the details into getting the protocol going. But now, how about we got this cart together, let's take it for a spin. But not from our perspective, but more from the patient perspective. So imagine you are in a room with 4 walls confining you, laying in a bed, looking up at the ceiling. Every 15 minutes or so, the IV pump starts to sound, and a nurse has to come in to try to turn it off. A few minutes later, someone from the cafeteria staff comes and tries to take your order. Then the hospitalist comes and visits you. Then you're referred to another specialist who comes and sees you. And then you have maybe a physical therapist or an occupational therapist see you, and on the cycle seems to go. And all you really want in this time when you're feeling pain, or when you're feeling some anxiety due to a recent diagnosis, or even for an upcoming procedure, is you want some calm, you want some peace, you want a moment to yourself, which is very hard to get in a hospital room. But instead, this is what you get to experience and immerse yourself in. And then all of a sudden, as staff, we end up seeing this reaction from the patient. Remember this morning, Dr. Spiegel mentioned that ah moment, or that moment of hope, that moment of belief, that moment that you kind of are in a different realm, not in the same hospital room. And from there, you can see the tears that come. And these tears, we've seen them on multiple, this is the most common emotional response we have seen from the patients. And it means the world. The other responses we end up seeing are things like happiness. Some people kind of revert back to a memory that they had and they bring it back up. And it kind of is like they get to remember where their mother went. Or if they're in a place of sadness because of their disease, they get to kind of take a step back and look inward. These are some of the patient reactions, quoted straight from the patients. We had a patient that started saying, I was very pessimistic going into this, but was surprised as how well it works. It was wonderful and relaxing. It was surreal, viewing the Earth and it spinning on its axis. It gives a different perspective. This perspective has been seen in a few patients for sure, especially in the scene where you kind of zoom out and you're looking at the world. Then we have patients who go into the sunset scene and say, it's emotional, how pretty it is. The bird is oddly close, feels like I'm camping or was at a rave. But then she ended up in the mountain scene, and the patient began crying when seeing a goat. Let me give you a little story on that, or back history. This patient, she's actually a mental health care provider, and she believes in equine therapy. She loves horses, she loves dogs, she loves all kinds of animals in general. And she was able to escape to her happy place by going into the mountains and seeing this goat in a hospital room. Here's more. Then it also helps as another way. VR can develop not only the nature scenes and just as peace and calm, but it serves as a mode of therapy. Even in these short moments where VR is only given for 15 minutes, patients were able to experience different kinds of therapy. In this slide, I talk about how many patients one was describing color therapy as something that they do at home. And when the first reaction they gave watching the scenes was the color spectrum of VR is wonderful. Instead of a narrow focus on the pain, VR and the starry sky scene helped opens one mind. And the pain only became a small little portion of the entire world that is out there. And then there was a patient who actually paints at home and does a lot of paintings and a lot of other artwork. And he began to say, I learned more from this than I can begin to put into words. And he had a great sensation in the gut area that he had never felt before, never once in his life. And the colors, the pictures were so artistic to him and surreal that he felt that he was in a dream that he never wanted to come out of. As I said, different modes of therapy. Many people seek meditation and to find that peace, but it's very hard in the hospital. And so many patients loved it because they wanted to meditate, and I meditate at home usually, so it was nice to be able to do that in the hospital. I felt completely immersed in a different world. And some people are limited by their disease, and it is really hard to get out. So we have patients that escape with it, and in that meaning, there was a patient who went to the forest. Wow, I really enjoyed it. My favorite part was being in the water. There was a stream that was going by. I love the water, and she hadn't been there in 16 years, and she was able to visit on the VR headset. So all in all, even though we have all these patient reactions that have been positive, there is still a lot of feedback that we get from them, and this is one of the strengths, I believe, that we have here at the Cedars-Sinai Virtual Medicine Program, especially with this inpatient service. Just as it was mentioned, we are an educational institution, and we're able to conduct our research in-house. So we have this feedback loop, a very nice and strong positive feedback loop. And that is, we use this cycle called the PDSA cycle, or the Plan, Do, Study, and Act. And this was something that I actually learned through the Master's in Health Delivery Sciences program that I'm currently enrolled in with Dr. Spiegel as the director. And what we do is we first start out we created the software, or Dr. Omer-Laurent did. And we study it, we develop it in-house, and then we actually get to implement this software and use it on patients. As we do this, we're passively collecting data through the headset, which is quantitative data and all the metrics and the metadata that Josh was mentioning, as well as the qualitative feedback from the patients. And we think this is actually one of the biggest things. Well, who is VR being delivered to? The patients. It should be the patient's perspective. If it's for them, it should be made by them. Maybe not literally, but getting their feedback is exactly what it takes to make it geared and patient-centered. And we are able to get that through our qualitative data. As while we test the software, we're constantly able to go back and fix it. If a patient said, I don't like the graphics, or this noise was bothering me, or maybe one of the sounds was a little too loud, or if the voice wasn't calming enough, or the meditation, all we have to do is we go to Dr. Omer-Laurent, because we are lucky to have him, and have him just go and reprogram it. So we kind of keep adjusting the software. And so the scenes that I even showed you before were from a prior version, and we've now made it into nature VR, which has become more and more refined. And then, like I said, we keep identifying new ways to improve, and we go back and we kind of start the cycle all over again. And then in the next few patients, they might get the newer version of the software. So we've also hit a few little roadblocks because it is still under a research protocol. It is difficult to recruit. We have a lot of people interested. It's just hard to get the word out. So as Josh said, we use the modality right now of email to get referrals, but we really would like to have it on CS Link or our EHR system so that it could just be a click of a button to request a referral. But until then, we developed this brochure to make it a little easier, and we hand it out to all the nursing units, or if we're walking by and someone sees our VR cart and says, hey, what's that? And we give them a flyer. So any healthcare provider in the hospital is able to actually refer them. All you have to do is on that flyer, there's a simple QR code. When you scan it, it will pop up into a little template email addressed to us, and it will ask for the patient's name, MRN, a brief pain history, and then our team takes it from there for doing the rigorous chart review, and we try to go deliver them some VR. So that's basically the email that will pop up. And so pretty much from here, what are the next steps? I mean, I was mentioning, and Josh was mentioning, we've already had the software developed, and we found some staff, which is within our own department, but we do have multiple studies going on, so sometimes it is very difficult to get to a patient right away at the hospital that's just down the street from us, but we have one VR cart, which we house in the medical library, and as we house it, we can't see as many patients at once. And that headset, if you look closely, is actually wired to the computer, which is why we need the cart to power it as well. So something we would really like is to make it a little less bulky, or at least not wired. And that was actually a goal of ours, and we have met it. Thanks to Dr. Omer-Laron, he is actually putting it on a more portable headset, things like the Oculus Quest, and we're able to take it and deliver it on that hopefully soon. It has been ported, but just hasn't been delivered to patients that way. It also is a little bulky right now because the headset that we use, like I said, takes in that metadata, which not all headsets have that capability. And because we're a research protocol, we're still having to collect data and go about it. And then we do have limited staffing. So eventually what we would like is to increase, the whole goal of this is to increase accessibility to patients. They want VR, we want to give them VR. We just are trying to find the means to get there. And so we're working on the more portable headset, and then the next part is, well, a research protocol. This one's unfunded right now. So we would like to eventually just get VR into patients' hands by maybe through the nurses. We still need clinical oversight, so we would like to have Dr. Omer-Laron or any other clinical psychiatrist or physician on board. But if a nurse can hand out VR when a patient is in need and they don't have to fill out the long surveys and data once we've validated our software, then we could just simply hand them a headset, let them go for a round of VR, and then go on to the next patient when they ask. And that's pretty much it. So thank you for your time. And if you have any other inquiries, you can always email us.